So a 50-year-old woman has come to her OPD with gradual diminution of vision in both eyes since 2 years. She also gave the history of undergoing presbyon laser blended vision correction 5 years back. So her uncorrected visual acuity for distance was 20/40 in both the eyes, and for near correction in the right eye was showing N18 and in the left eye it was N5. And on examination we found out that the right eye to be dominant and NCT of both the eyes were 12 mm of HG. So on examination, the patient was orthophoric on the cover test. Extraocular movements were full, free and painless. Anterior segment findings, the cornea, we noted a 8 mm femtolasic scar with a clear interface, and gonioscopy of both the eyes revealed open angles, and pupil was well dilating up to 8 mm. And coming to the lens, she had a posterior subcapsular cataract with a nuclear sclerosis of grade 1, and the dilated fundus revealed a normal fundus. So coming to the pentacam, the K1 of the right eye was 44.3 and the K2 was 44.8, and the Q value is minus 0.48. If you can see the quad map, especially the pachymetry map, the center part of the cornea is slightly steeper compared to the paracentral area. So this indicates that she might have undergone some hyperopic laser vision correction previously. So coming to the left eye, the K1 is 46.4 and the K2 is 47.0 diopters, and coming to the Q is minus 0.69. And in the same, the left eye also, the central cornea, if you see the pachymetry map, it seems to be more steepened than the paracentral area, indicating that she has undergone a hyperopic laser vision correction. So the IOL calculations were done using the IOL Master 700. And we've taken different formulas into consideration, but we went forward with the Barrett-Truquet TK formula. So monovision cataract surgery with a aspheric IOL was planned for her to achieve a good vision for near, intermediate and distance, and not to induce any new spherical aberrations. So the IOL power that we got was for right eye it was plus 24, and for the left eye it was plus 22.5. A monofocal aspheric IOL, Zeiss CT Lucia, was used for her. First, we operated the left eye and then we have operated the right eye. So a routine phacoemulsification surgery was done using a 2.8 mm incision, and the procedure was uneventful in both the eyes. Post-op period was uneventful. So binocularly, the patient maintained a distant corrected vision of 20/20 throughout the 6 months post-op follow-up period. So if you can see, these are the refraction that we have got from the post-op period. Binocularly, the patient at 6 months was maintaining 20/20, and the near binocular vision was also N5. And we come to the Z4 values, it was minus 0.613 in the right eye and 0.483 in the left eye. And the defocus curve coming, it has shown two peaks from minus 0.5 to plus 0.5, with a visual acuity of logMAR 0.0. That means she has a very good depth of field. So using Salzburg reading desk, we have one in at 40 centimeters, she was reading 162 words per minute and 164 words per minute at 66, stating that she is comfortable in reading 40 centimeters and 66 centimeters. So the patient was being comfortable with the laser blended vision correction for 5 years. So we have planned the similar thing to be done with the cataract surgery also. So we used the Barrett-TK-Truquet formula. And usage of aspheric monofocal IOL is done not to induce any new spherical aberrations, because this will, once the new spherical aberrations are induced, this will, whatever depth of field is there for her, it will be not there anymore. And EDOF lens are not suitable in such kind of patients because the retinal image quality will be decreased. So the key thing is always go for a monofocal aspheric IOL to maintain a good distance and a near vision. An appropriate IOL calculation has to be done in patients who are undergoing cataract surgery post-refractive surgery. So in this case, we have chosen a Barrett-Truquet TK formula. These are my references.
Thank you.
Thank you.
It was a nice presentation, well presented and well managed case. I just want to ask you one thing, that I mean, most of the things that you presented is now an established fact. So anything new that you would like to convey from your presentation?
What he wants to ask is, why are you presenting this?
Because the thing is that it's a hyperopic LASIK. Hyperopic LASIK, it's presbyon itself is not done very much. And patient who has presented a cataract after undergoing a press biond, and it's always challenge to calculate and get the correct IOL power, especially in post refractive, and that's also it's a post press biond surgery.
Dr. Prakhya, did you do you advocate the use of advanced monofocal IOL in such a case instead of a routine aspheric IOL
No, ma'am.
for a good intermediate kind of vision? Because you've not measured intermediate vision in your case. And do you have a pre-operative refractive assessment of the patient? Because you said the distant vision acuity was pretty good. It was
Yes, ma'am.
20/40. So
Yes, ma'am.
and the patient complained of reduction in vision.
Yes,
So did you
yes,
do a
ma'am.
refraction to see if she's improving?
Yeah,
with
we have done,
NS1?
but actually I didn't include in the presentation, but we have
So
done.
was it
yes.
myopic or hyperopic? I just want to know that.
It was
Because with
myop-
nuclear sclerosis, it is.
Yes,
And with the myopic correction, the patient was having N18 vision.
yes, ma'am.
But after surgery with monofocal, she's having monofocal implantation. She's
Yes,
having
ma'am.
N5.
Yes, ma'am.
So how does it
But
correlate?
it's binocularly, ma'am. It's not
No, you
uniocular.
said uniocular N5. In your presentation, you've
Only
written
in-
right eye, left eye, both N5.
Only in the left, that's binocularly, it's near visual acuity is N5, ma'am. But the
But
left eye,
pre-op it was not N5.
no, ma'am. Pre-op it was not N5.
So it was a myopic error, but the near was not.
Yes,
did
ma'am.
not. Little.
Basically, he means to say that maybe because of the
Yes,
cataract.
because of
and
the cataract. Yes.
anyways, thank you.
Thank you.
Thank you, sir.